I want to thank everybody for being here, especially as we tackle an issue that, unfortunately, is something that, I've seen ever since I've got into Congress in 2016. And although we've taken affirmative steps to address the opioid crisis, it just continues to spread. And it continues to spread throughout the country, into our communities, and unfortunately gets to a point where it can absolutely shatter families. And so I really appreciate my colleagues at all levels being here, because I think what we've seen is that this is an issue that isn't going to be addressed at the local level, at the county level, at the state level, or at the Fed level. It's an all-hands-on-deck approach. And what I've seen in my limited time in this position is that when it comes to these types of difficult issues, that's what it takes. That's what it takes. And so it is an honor to have my colleagues here as we talk about this. I can tell you from the federal level, like I said, I came in 2017. And obviously there were a lot of analyses as to what was going on politically back in 2017, possibly as it will be in 2024. However, I think you have to look back then, and you have to look at the certain areas that the analysis went into. And they were these states in the heart of the country that were dealing with a lot of depression and therefore dealing with a lot of escapes. And part of that escape was the use of opioids, in which I heard from my colleagues in the middle of a country, especially Ohio. I'll never forget a good friend of mine, Representative Congressman Tim Ryan from Ohio, yelling about the opioid epidemic. It was back in 2017. And then in 2020, I hear my colleagues in Philadelphia talking about the epidemic that has hit their town. And it's beyond just fentanyl, but these kind of cocktails of drugs that we're seeing, in which you're seeing these drug dealers be more and more, unfortunately, creative when it comes to fentanyl, especially in this drug called tranq, which is fentanyl mixed in with xylazine. Xylazine is an animal sedative that is properly used by veterinarians and by cattlemen to induce sleep in large animals. And so with that, we immediately jumped on it at the federal level and made sure that there were certain scheduling and reporting of that drug that needs to be done. And we're working on that in the United States Congress with my bill, bipartisan bill, that has passed out of the House and is now in the Senate, along with the SUPPORT Act, which is an overreaching bill that was passed in 2018 to deal with the opioid epidemic. And now that needs to be reauthorized. And so we passed it out of the House. It's now in the Senate. In addition to that, and I think I'd be remiss if I didn't mention it, I think you're seeing the federal government step up when it comes to dealing with the prevention of fentanyl crossing our borders. I think we're seeing those numbers grow, especially with the data. But I also think that's why this administration, the Biden administration, has asked for increased resources, not just millions, but billions, when it comes for increased resources to go to our border so that we can continue to stop the flow of synthetic opioids that are crossing into the United States of America. But in the meantime, it is my responsibility as the federal representative for the 19th Congressional District to continue to hear from those who have their boots on the ground, to continue to hear from those at the county level, at the state level, and of course at the city level, as to what else we can be doing at the federal level to ensure we're playing our part, but also to develop that partnership that all-hands-on-deck approach that I believe is so necessary to tackle the tough issues. And unfortunately, one of those tough issues is the spread of fentanyl into our communities, and unfortunately something that can break our families. But I think if we come together, and what I've seen, if we develop these partnerships, if we listen to one another, if we learn from one another, that is how we provide solutions for each other and for our families. And so I'm very honored to be a part of this roundtable. Again, apologize for being late. And so it would be nice to have other people speak at this time and not just listen to me. And so I would turn it over to the president of the Board of Santa Clara Supervisors, Susan Ellenberg.
Thank you. Thank you, Congressman Panetta. Always wonderful to see you and very appreciative of your leadership in Washington, D.C. I particularly appreciate your bringing together this group of dynamic leaders and experts and stakeholders to have one single conversation. I think you are 100% right that this crisis will only be meaningfully addressed if we work together. Before I say a few words about how the Board of Supervisors is addressing the crisis, I want to take just a moment to set a larger stage. There are 58 counties across the state of California. For every one of us, our core service, whether rural, urban, or suburban, is to provide safety net and social services to individuals who have no other resources. In Santa Clara County, more than a third of our $11 billion budget is allocated toward our health and hospital system. We own and operate 3 hospitals, a dozen or so clinics, and we partner with a number of community-based clinics to provide vital services in trusted settings. Counties have struggled with increasing rates of mental illness and substance use disorders among the populations we serve. Since the passage of the Mental Health Services Act in 2024, there has been scant new funding to address growing needs. In 2022, I led my colleagues to declare a public health crisis in mental illness and substance use disorders. We did this in order to vault the issue of addressing mental illness and substance use disorders at the highest county level. As a result of that, Behavioral Health Department created a strategic plan that laid out exactly how many more beds we need, at what levels of acuity, what kind of workforce we need to develop, and how we're going to increase treatment slots, inpatient and outpatient, mental illness co-occurring with substance use disorders, and standalone substance use disorders. Shortly after we declared that public crisis, the state legislature went into high gear on mental health and substance use disorder issues. In just the past 2 years, we have seen payment and rate reform for Medi-Cal, the creation of care courts, the passage of expanded conservatorship eligibility terms, and Prop 1 on the March ballot includes a $6.38 billion bond for mental health-related housing and a reconfiguration of permitted Mental Health Services Act spending. In this milieu of new mandates, growing needs, and unacceptable deaths, we clearly have our work cut out for us. The county's plan to combat opioid crisis focuses on 4 areas: prevention through education, harm reduction, recovery, and treatment. Under this framework, the county has implemented a number of successful programs and initiatives, including the Santa Clara County Opioid Prevention Program, that's a lot of letters, between Public Health and Behavioral Health Services Department, has implemented dozens of initiatives, both of their own design and as a result of input from the county's fentanyl task force that was created by Supervisor Cindy Chavez and District Attorney Jeff Rosen in partnership with our Behavioral Health Department's addiction and substance use disorder treatment specialists. Some of the prevention and education initiatives include FentFacts, which is a social media campaign about the raising awareness of the dangers of fentanyl. It's tailored to appeal to and reach residents ages 14 to 29. That campaign to date has received over 3 million views across various social media platforms. We've also partnered with the Foundation's Song for Charlie on a campaign to increase awareness about the fake pills masquerading as something else and containing fentanyl. Our Public Health Department's harm reduction program has focused on making naloxone broadly available. We've increased 609% from 2021 to 2022 in distributing intranasal naloxone doses. We saw a 338% increase distributing intramuscular naloxone doses and a 73% increase in distributing fentanyl test kits. Increased access to medication-assisted treatment services is another big part of our effort to reduce harm. In custody and at 5 designated locations across the county, we are offering those medication-assisted treatments as well as peer support programs. Naloxone distribution and training has been provided to all Santa Clara County school districts, all 31 of them. All have received Narcan kits. We've launched a free mail-order Narcan program. We have provided Narcan vending machines across the county in our jails, at community centers, at colleges, and libraries. All county libraries have received training and Narcan through the Santa Clara County Opioid Overdose Prevention Program, and we offer ongoing trainings at our public libraries. This is just some of what the county is doing with our resources and within the scope of our purview to address this crisis. The ever-changing landscape due to new unregulated substances entering the market means that we are constantly a step or two behind the market, behind the deaths, behind the manufacturers, and behind the sellers. Thank you again, Congressman, for bringing stakeholders together to have a discussion. And I really do want to take a minute to appreciate the breadth of folks who are up here. If we were to have this conversation without law enforcement or without addiction medicine specialists, without public health directors and elected leaders at every level, we would really only be able to see pieces of a puzzle and not a whole picture of what we need to do. So thank you, and I look forward to the conversation.
Thank you, Madam President. I appreciate your words. I appreciate your work, and of course your collaboration, and of course for hosting us here today. Thank you for that. I think you bring up an excellent point that I failed to address. Obviously, I failed to address. I talked about all levels of government, but it's not just vertical. It's obviously horizontal in the methods of how you do that, from obviously rehabilitation services to remediation services to prosecution and enforcement efforts as well. So I believe that's kind of what we're realizing in Congress as well. So thank you for that. It's a real honor to have someone that I've been that I've been able to work with ever since my congressional district kind of got shoved into South San Jose. And that's, yeah, exactly. And like I said, I love Highway 101. I'm not going to get in a love-hate relationship with that one. But Mayor Mahan has been instrumental in a number of areas when it comes to dealing with these issues. And I what I've seen in my limited time working with him, he really understands that kind of all hands on deck approach to these tough issues, be it housing, be it mental health, and of course, dealing with the fentanyl crisis. So Mayor Mann, thank you for your work. Thank you for your leadership. Please.
Well, thank you, Congressman. I appreciate you bringing us all together. Good morning, everyone. Thank you for being here. Look, and I'm just going to go off the cuff with a few comments, and I'm mostly here to listen and learn from colleagues on the panel. But from where I sit at the city level, it's pretty clear that we face a public health and public safety crisis that we have to do a better job of addressing. With the limited resources we have, we should be clear about the budget constraints that are very significant here. I know the federal government's got its challenges, obviously state government facing a very significant shortfall, and I don't think you're going to see a big expansion or new dollars available at the local level either for the next couple of years. And so we have to figure out how to have a greater impact on this issue with existing and hopefully not shrinking resources, frankly. It's an important issue for me because I see the impact it has on our families in San Jose. I see the impact it has on public safety and the nexus with crime that our police officers are on the front lines of addressing every single day. I see the nexus with our homelessness crisis, maybe less in causing it, though certainly related, but also in trapping people and making it harder for people to turn their lives around and get out of homelessness. At the city, we have 800 city employees who have been trained in the use of Narcan, which is, of course, available in our patrol cars and fire engines. We're now looking to expand that to libraries and other city facilities. And while it is an important tool for saving lives, it frankly is in many ways a Band-Aid. It's very downstream of the solutions we need. We've got to do a much better job of stemming the flow of opioids into the country. We've got to do a better job of law enforcement and holding people accountable. I want to recognize our DA, who was one of the first in the state to actually charge folks for murder for the sale of fentanyl, for providing it to someone and leading to their death. I think we need to treat it as the very dangerous substance that it is. It's as bad as the drugs were when I was growing up. These drugs are on a whole other level in terms of their addictive properties and their lethality. I personally believe that we've got to both stiffen penalties for those who are trafficking and dealing. We also have to better address the demand side. If we learned anything from the drug war of the last quite a few decades now, I think it's that overly focusing on supply without getting serious about addressing demand is going to be ineffective. And that's going to have to take a few different approaches, again, in my view, based on what I see at the city level and what I hear from our city staff who are really on the front lines of this crisis every single day. And to be clear, the city does not run the healthcare system, which is why I'm so interested to be here at the county and hear from our public health experts. But in terms of dealing with the demand side of this problem, clearly we need to make treatment more accessible and we need to meet people where they are. We have folks who desperately need treatment, but signing up for it, getting an appointment, and not being able to get there because you're living in a tent down by the creek and you're living with the uncertainty of life on the streets doesn't make that treatment option all that viable or useful to you, just as an example. We need much more inpatient treatment at all levels of acuity. We need the severe and in fact even secure facilities for those at the very extreme end, down to much more inpatient and residential treatment options. We've got to help people get other things in order and have enough stability that treatment can actually be productive. I also personally believe that when one's addiction has gotten to a point where it's threatening their lives, the lives of others, and having a very significant impact on the community, that the community has an interest in compelling people into care. And I understand that's controversial. I don't support forced medication, but I think that we have lost tools. We have lost the leverage for being able to say to someone whose addiction is so severe that they're at risk of death and they're harming others, and they're harming the community. It used to be easier to say, you can go to jail or you can go to treatment. And we have made that harder for our judges to do. And so as we look at this constellation of policies that are coming forward and things that are on the ballot, we look at SB 43, we look at Prop 1 coming, I think we're going to have a conversation about what is the community's interest in strongly making it accessible, strongly encouraging, and in what is hopefully a very narrow set of very severe cases, compelling people to at least have enough time to detox. You need a couple of months, maybe longer, we'll hear, to really get to a place where you can maybe make a different set of decisions about your self-care. So I'm a pragmatist. I think that on this issue, we are not where we need to be. We need a broader set of tools, and we're going to have to figure out how to do it with the limited resources we've got. So I don't know if that's a useful dose of reality, but going out to our encampments every week, talking to our police officers and our firefighters and the folks in our libraries, I think we're going to have to admit that the set of tools we're deploying today are not sufficient for the crisis that we're seeing unfold out on our streets and in our community. But appreciate you convening us, and I'm really excited to continue the conversation, figure out what we can do differently to change the trajectory that we're on.
Absolutely, Mayor. Thank you very much for that insight and for that dose of reality, and especially what you've seen, I'm sure, with your officers who obviously are on, like I said, are on the front lines or have their boots on the ground and are in these encampments and are actually dealing with people who are affected, unfortunately, by the scourge of fentanyl, by the scourge of these opioids that we're seeing on our streets. Obviously, someone else who is dealing with that at the county level is our Undersheriff Ken Binder. Robert Johnson, the sheriff, has basically was one of the first people that I met with to talk about this issue several months ago, and I appreciate his leadership. And so, thank you for being here, Undersheriff Binder. Please.
Thank you, Congressman Panetta. It's such an honor to have you here with us this morning, along with the others. And what I'd first like to just say is that this really is not an issue that's happening in someone else's neighborhood or over there somewhere. The opioid crisis and fentanyl in particular is happening everywhere, all across the country, all across the state. And Santa Clara County, unfortunately, is also facing this crisis as well. We're very fortunate that we've got excellent leadership with our Board of Supervisors, and President Ellenberg so eloquently stated some of the amazing things that they've done to lead the charge against this crisis. And so I feel sorry for other counties that don't have that focused effort against it, because I think it could be even much worse here, but it is here in Santa Clara County as well. And in fact, in the last 5 years, there have been 639 overdose deaths in Santa Clara County, according to our behavioral health department, and 416 of them involved fentanyl. Opioids, and fentanyl in particular, are having a devastating impact on our youth and our young adults. And as Congressman Panetta mentioned before, it's destroying families. Our teenagers are accessing fentanyl, and in many cases, the parents have no idea. And they're using these drugs, and since 2020, it's killed 159 people under the age of 30 in Santa Clara County. Nationwide, fentanyl is involved in 4 out of every 5 Gen Z drug deaths. You heard about Nazolone, the Narcan spray. Without that spray, the death toll would probably be 10 times or 100 times higher. It would be much, much higher. I can tell you that our Santa Clara County Sheriff's deputies have actually prevented the death of dozens of people in the last few years just by administering the Narcan. So how are teenagers accessing these drugs? They're making deals on social media platforms, and I'll talk about that a little bit later. But that's important to know. And the potency, you heard Mayor Mahan talk about the potency of fentanyl. Fentanyl is actually 50 times more potent per pound than heroin. It's 100 times more potent than morphine. There's a distinction we're seeing with the drug overdose deaths now as opposed to in previous years and previous generations. It used to be that an overdose required a large quantity of drugs or a bad mixture of drugs or some bad batch. But fentanyl's different. The amounts are so small. We're talking the size of a grain of salt that can be deadly. And so the death rate is climbing at a really high rate and a steep curve. There's an upward trend. In 2022 alone, there were 160 fentanyl-related deaths in Santa Clara County. That's 15 times more than we saw in 2018. Because fentanyl is a powerful opioid, it's highly addictive. Mayor Mahan talked about the demand and treatment. such an important factor that cannot be overlooked. It's so addictive, and people cannot come off of this drug by themselves, by and large, for the most part. In order to detox, they need to be under a doctor's care, and it does take months, at minimum 1 month, preferably 3 months under the care of a doctor with medication to help the physical addiction that the person is struggling with to come off. Then you have the mental aspect. It takes mental fortitude to come off of this type of a drug, and that's treatment. That's teaching people how to look at their own problems, their own depression, their own life, the world differently. And that's not something that just happens overnight. And so that's an aspect that cannot be overlooked. Fentanyl and opioids, well, fentanyl is also being mixed with other drugs now. It's no longer just methamphetamines that we're seeing on the street. Used to be the highest drug we always saw out there, but now the meth is being mixed with fentanyl. They're putting it in everything, in heroin, and because of that highly addictive quality, the users are even more addicted to whatever drug of choice. And there's many times where the user doesn't even know that fentanyl is in there, but the dealers are putting it in there to get their victims addicted. So what are we doing in Santa Clara County? Obviously, this county is addressing it on a multifaceted front. I can only speak to the law enforcement front. But the Santa Clara County Sheriff's Office and our county task force as well, our narcotics task forces, they're approaching overdose deaths differently now. We've put together on-call mobile response teams when there is, and it's still reactive, but when there is a death, to come to the scene right away and to start collecting evidence that's critical to start holding these drug dealers accountable and to get investigative leads. And it is personnel resource intensive. And when they investigate these crimes, they're looking at the drug dealers, and there's a big difference between charging someone with drug dealing and holding them accountable for pushing a product that they know is killing people. And they're pushing this product into the hands of teenagers, teenage girls, teenage boys. They're wrecking families, they're wrecking lives. And so we're very fortunate in Santa Clara County that our district attorney, Jeff Rosen, is prosecuting these cases for murder and holding people accountable for the deaths that they're pushing on their victims. And right now there's a number of cases working their way through the court system. And I want to applaud not only District Attorney Jeff Rosen, but every DA up and down the state. There's ones in Northern and Southern California right now that are doing the exact same thing. They're pushing murder charges on drug dealers who know that the product they're pushing is directly causing the deaths of people. So, what do we need? What kind of help can we have? I just have two main areas, and that is funding and legislative help. And of course, everyone always wants money and asks for money, but the fact is, it's hard. There's not many problems that can be solved without a money solution. Just about any problem you have out there. I have an issue at my house. I got to pay someone to come fix it. Well, it's expensive to have on-call teams ready to respond and investigate, to be properly equipped, and to be properly trained. It takes time and money. Treatment programs are very expensive. They're time intensive. They're personnel intensive. And it could easily break the bank of any county, city, or state that really wants to address it in the manner that is truly needed to solve the problem. in regards to the legislative gap. I mentioned before that our youth especially, but a lot of people, almost all of the drug deals and transactions are being made through social media platforms. These companies know that this is occurring on their platforms, but they're unwilling to do anything about it. Our social media companies know the profiles of their users. That's why you get the app for free. You tell them all about yourself. They know what your use patterns are, your viewing patterns. They know what your politics are. They know what your religion is. They know what your spending habits are and what stores you go to. Don't tell me they don't know when these drug deals are happening on their platforms. They know, and they're refusing to address it, and they're not dealing with it. They have engineers, they have algorithms, but it's a hot potato for them to touch the drug issue. They don't want to. I would like to see some type of legislative pressure to hold social media companies accountable for these transactions that are happening. At the very least, when they know it's happening, they should be kicking these people off their platforms and not letting them back on. At the very least. It wouldn't hurt for them to consider sharing some information with local law enforcement to help save lives for offenders who are making drug deals all over their platforms, and they know who they are. These companies are also very profitable. They could put together teams of safety analysts to go through the data and to share information that could potentially save lives with local officials. Again, thank you, sir, for being here, and thank you, President Ellenberg and Mayor Mahan. We appreciate the efforts that you guys are all doing. And my name is Ken Binder, by the way.
I was corrected.
The undersheriff here in Santa Clara County. Happy to represent Sheriff Bob Johnson, who has a keen interest in this issue here in Santa Clara County.
Undersheriff Binder, thank you very much. I apologize for the mispronunciation, but very appreciative of your structured report and analysis, and like I said, going after talking about not just the issues, but appreciate you bringing up the potential solutions at all levels. So thank you for that. One of the things that you hit on was this, like I said, the cocktail of what's going on with some of these opioids and how tranq is, like I said, this mix of fentanyl and xylazine. One of the aspects of that mixture that really scared me is not just the results, the impact on the human body leading to potential necrosis. I mean, I wouldn't recommend Googling tranq because you'll see images that you cannot unsee. But in addition to that, Narcan is impervious to fentanyl mixed with xylazine, to tranq, because of the sedative nature of xylazine. And so no matter how many pumps of Narcan they give them, they do not wake up. And so that's why I think it's very important to highlight that potential mixture and spread of that drug tranq coming into the community. Obviously, it's great that we have not just law enforcement, but treatment professionals. We're joined by Dr. Sarah Rudman, who leads the Infectious Disease and Response Branch of the Santa Clara Public Health Department. Dr. Rudman is helping lead the charge for our community to respond to public health emergencies like the opioid and fentanyl crisis. Dr. Rudman, thank you for joining us.
Thank you so much, Congressman, and thank you to my colleagues here and especially to the board for their ongoing support of this incredibly important work. I've been with the Public Health Department now for about 7 or 8 years, initially focusing on our harm reduction work. And as the board president described, we have seen a skyrocketing of the need in this arena. And part of the reason that was public health's role when I began was that we were actually flexing infectious disease dollars to be able to do this work that was saving lives, not just from HIV, from hepatitis C spread when folks share drug equipment, but because we were able to use it to save lives from overdoses. And that idea of flexibility, of trying to make sure that we have the authority we need to use the resources we do have where we need them, is a recurring challenge for us while we are using, exactly as folks have described here, all hands on deck for this very complicated problem. But fortunately, in the years since I've been here, I've seen public health evolve what our role looks like. And just as the public has seen us act in other crises in the last several years, we've needed to fill specific gaps that our healthcare service experts, that our law enforcement experts either can't reach or shouldn't need to, because it should be our job to step in and prevent someone from needing justice involvement or needing treatment. So the Public Health Department is aiming to serve and solve this problem in several ways. One is around using data and the best health evidence we have to understand the problem, who's being impacted. For example, in Santa Clara County, why we are seeing worsening racial disparities in terms of populations of color dying more and more frequently than white populations, and increasingly so from this epidemic. We also use our scientific expertise to evaluate solutions, see which ones are likely to work, and then test to see if they truly are and get that feedback to the folks on the ground doing the work. We also coordinate with community members, with folks impacted by addiction or by loss of loved ones, with expertise in treatment or law enforcement, to make sure the solutions we're putting out there are guided by that expert and by that lived experience. And then we also step in key service areas where our colleagues simply can't, such as initially in the harm reduction world. So some of what that means for us here in Santa Clara County is that the Public Health Department has benefited from a recent grant by the CDC, the Overdose Data to Action grant. And this has allowed us to step up in exactly those areas that public health needs to play a key role in building overdose data systems to get the best information to the folks who need it, to help all types of healthcare providers, not just addiction experts, have the information they need to know what their patients are experiencing and point them in the right direction, to link people to the types of services they need and navigate the complicated healthcare system around addiction, including maximizing use of telemedicine wherever we can, to continue to spread harm reduction both through our own service delivery and through helping other sectors use those same harm reduction principles to help keep people alive and safe while they transition to recovery, and to explicitly fight the stigma around substance use and addiction that is keeping people from talking about it, whether it's before they decide to use anything, when they're starting to experiment, or when they're deep and suffering from addiction. So part of what I'm hoping to see from this conversation and from our ongoing collaboration from the city, from across the county, across the state, and with our federal partners is to allow us to continue to maximize that flexibility and to really modernize the way that we are responding to this crisis so that we can evolve faster than these drugs are evolving. So that every time we see a new drug like tranq and xylazine, we are ready to modernize faster than the drug dealers are. And so I'm thrilled to know that you are a supporter of the Modernization of Opioid Treatment Act. Another modernization effort that's actually critical to how public health plays a role is the CDC data modernization work that allows us to have the information we need across all sectors to protect people's privacy, but still understand the patterns we're seeing and get information out to folks. We also need the infrastructure to be able to be flexible across these areas. And so things like the Public Health Infrastructure Saves Lives Act also help us fill these gaps that the service sector and the law enforcement sector simply can't, to help offload how many folks we're ultimately sending to my partners at this table. And then finally, specific flexibilities where we have limitations at the federal level are still stymieing us. One example is there's still a federal restriction that bans us from using federal funding for harm reduction efforts, like syringe access, safer alternatives to injection, fentanyl test strips, key activities that we have proven here in Santa Clara County save lives and get people to recovery. So I'm very pleased to have this conversation with you so that we can figure out how to use every resource we do have for this massive problem. Thank you.
Great. Thank you, Dr. Rudman. I appreciate that. Obviously, speaking about behavioral health, we're lucky to have Dr. Cheryl Ho, who's joining us from the Santa Clara Behavioral Health Services Department. Dr. Ho is an expert in addiction medicine and an advocate for medication-assisted treatment as well as care in our homeless neighborhoods and their needs. In 2017, she was awarded Clinician of the Year by the Association of Clinicians for the Underserved. Dr. Ho, welcome. Thank you.
Thank you, Representative Panetta, for just convening this group. I really appreciate the opportunity to dialogue. It's very rare that we all get to sit together at one table. As you mentioned, my background is in primary care. For 20 years, I cared for individuals as their primary care physician for folks experiencing homelessness, and actually 2.5 weeks ago joined this new role together with my wonderful colleagues at the Behavioral Health Services Department. And the reason I did that was I was beginning to see week after week deaths of my patients from fentanyl, and really felt that I really wanted to join the team around just really focusing on what we can do in this time of crisis. Thank you for your legislative efforts that you have put forth, with the bills that you talked about. I really appreciate all that you've done. There's a couple of things that I wanted to bring up that really, on the federal level, have bearing on the treatment of folks with addiction disorders. To be honest, that have made it a little bit harder for me to be able to bring treatment in the way that I would see clinically appropriate. I think the first one is the ancient 42 CFR Part 2 Code of Federal Regulations. And what this is, it's a restriction on folks' medical records who are receiving treatment for substance use disorders. And it actually holds this privacy up to even a higher standard than the rest of the medical system, which is, you may be familiar with the HIPAA regulations. And so as an example, we are trying at this county to bring a hub clinic to bear, which is for a treatment, a clinic for folks with substance use disorder where they can receive medications for addiction treatment. But because of this ancient 42 CFR Part 2 that's in place, I cannot coordinate with my colleagues at the hospital level. I cannot coordinate with their primary care doctors. If I'm trying to focus on non-fatal opioid overdose, I cannot kind of coordinate efforts in any way because of this ancient kind of restrictions around people with substance use disorders. I know that there has been some proposals put forth by Health and Human Services to actually align 42 CFR Part 2 with HIPAA to be able to have us coordinate across the system. And so I see this as a critical piece in our work because right now it's really hampering our ability to, as you mentioned, put all hands on deck in the treatment of this crisis. The second thing that I'd like to bring up is, as my colleague Dr. Redmond mentioned, is we really appreciate that you had signed on to the Modernizing Opioid Treatment Access Act, also known as MOTA. Just as buprenorphine really was, the landscape was changed with the Data 2000 Act and putting buprenorphine prescribing into the hands of everyday physicians, I really support, along with the American Society of Addiction Medicine, this expansion to access of methadone. Clinically, I do find that a lot of my patients would prefer to start on methadone over buprenorphine, and so this act really would allow the expansion of methadone access to the patients who really need it. I think this is especially relevant in the rural settings, where often there is no methadone clinic that patients can go to. And finally, I also wanted to address the flexibilities that are in place with the Ryan-Haight Act. So the Ryan-Haight Act was put into place initially to tamp down some of the perhaps egregious prescribing practices around opioid medications, really meant in place, for some of that online or teleprescribing. But to be honest, there were some flexibilities that were put into place during the COVID-19 pandemic that allowed for the beginning of medications over the phone. And it actually has been helpful in the treatment of folks with fentanyl use disorder because we've been able to prescribe buprenorphine over the phone through a televisit, so accessing folks in encampments who may not have been able to come in. And so I've been able to prescribe people without a face-to-face visit. And so, I understand that the flexibilities around that will sunset at the end of this calendar year, and I really hope that those flexibilities for telemedicine will continue. passed this year. So thank you again for this.
Thank you. I appreciate that, Dr. Ho. And obviously, we've seen the growth of, ever since COVID. Telemedicine has played a more of an impactful part in our healthcare systems. And so obviously, it's something that when it comes to treatment, that's understandable how important it would be as well. So thank you for that. Just so I don't screw it up, Dr. Granovator, can you pronounce it correctly?
Binder.
Thank you for that. Exactly. That's exactly why I asked. Learned my lesson on that one. Did I?
You did fine.
Okay, great. Dr. David Granovator, lastly, is who we're joined by, fortunately for us, who's an addiction medicine specialist who serves patients throughout the Bay Area and up over the hill into Santa Cruz County. He sees patients daily, working to overcome opioid and fentanyl abuse. Doctor, I'll leave it at that. Thanks for being here.
Yeah, thank you, Congressman Panetta. I live in South San Jose, so I'm in your district. So it's my honor to be here, and Board President Ellenberg and Mr. Mayor and everyone else on the panel. I have it's an honor to be here. I have the privilege of being the last one to speak, so I can say I agree with everyone that spoke today and everything they said. And I feel a lot of gratitude for being able to be part of this panel, and just being able to convene something like this, I think, is a milestone, and is an amazing start, to continue our fight, for this horrible opioid and overdose crisis. Addiction is a disease. It's a chronic disease, meaning it's lifelong. People relapse, they get treatment, they get better, they can relapse anytime, and it requires a chronic disease model of treatment, just like diabetes and high blood pressure and other chronic diseases. And I'm happy that I work with a large medical group, that focuses on chronic disease models and preventative care. But that's one part of the problem, and the other part is dealing with all the people who are dying and struggling, and who have social situations that don't permit them to get treatment. And I'm very grateful for all the efforts that are being made at the city, county, state, and federal levels, and we can do better. We always can do better. We're lucky, I think, compared to many other parts of the country, many of which have absolutely no access to treatment. I think the statistics are 50% of counties in the country don't have practicing physicians that are trained in addiction medicine, and those are often the places that have been hardest hit with the epidemic and crisis. So in a way, we're fortunate, and we do a lot, and we could always do more. So, Kaiser is attacking the problem on several fronts, like everyone else is. So I'll discuss some of them. First, we've made Narcan, readily accessible in the emergency rooms and all the pharmacies, and I think maybe we'll have to get a hold of some of those vending machines. I think that would be a great idea. And also, any patients at risk for addiction of any sort, or people on combinations of opioids being treated for pain, we make sure that they're prescribed Narcan. So it's like everyone has Narcan, in their medicine cabinet. I really believe that should be like one of these things that everyone should have, access to. And then we've created a no wrong door approach, for medically assisted treatment. So medically assisted treatment basically, I think has been mentioned, means access to medications that can enable folks to deal with their addiction and feel reasonably functional, to be able to get off their deadly opioids, and be on medications just like for other chronic illnesses that they take every day that can help prevent, them from relapsing and going back to using. And we can make this treatment accessible, but again, like for a lot of the populations that were talked about today, homeless populations, others, accessing treatment is extremely difficult. And addiction is one of those diseases, that first of all tells you don't need treatment, and it robs individuals of being able to make conscious decisions and good choices. This is the way it works on the brain. So that makes it extra hard to be able to, you can have the treatment there, but you have to be able to either bring the treatment to the people or the people to the treatment. And that's, I think, is the challenge that I'm lucky that I don't necessarily deal within my little bubble of a, medical group, but, we want to be able to support the community and public health measures as much as we can. So, we have a no wrong door approach for medically assisted treatment. So buprenorphine is readily available. We're trying to make it more standard to be able to be given by all primary care doctors. A year ago, HHS got rid of the requirement for a special DEA certificate that you had to have to prescribe buprenorphine. And now anyone who has any DEA, certificate to prescribe controlled substances can prescribe buprenorphine. And, as Dr. Ho mentioned, I would certainly support, legislative efforts to get methadone sort of in the same category. Right now, methadone has some fairly strict federal regulations regarding its use. It was only given in specialized clinics, and Kaiser is not licensed to give methadone for substance use disorders, but, patients who have Kaiser insurance can get methadone, but, we have to refer them to some of the county clinics, and be able to bring that in-house would certainly give some more options. So having options for treatment, so that, we can treat almost anyone would be, wonderful. And we've also used care extenders. We use a lot of clinical pharmacists. So I think we'd support any legislation that helps increase care extender access to medically assisted treatment as well. So you don't have to necessarily be a licensed physician. You can be a pharmacist, or a nurse practitioner, or a physician assistant to be able to provide this kind of treatment. And I think we have to kind of rally the troops and get everyone out there to be able to afford treatment. So, we've also done a lot of education for physicians on proper use of opioids. We follow federal, state, county, local guidelines for using opioids in chronic pain, which, as many of us know, has been in the media a lot in the last 5 years as being like one of the sparks that, led to the opioid epidemic. Was, a lot of opioids out there being prescribed, and then, we still have many patients who, they're addicted to fentanyl. They come in, we see them, and, we go through the history and you ask them, like, how did you become addicted? And it always starts with an initial prescription for many of these folks. So, it's not just young people getting it on the internet. Anyone, any age, any demographic, it's definitely no holds barred disease, that anyone can be subject to, and as far as the xylazine problem, we're just starting to try to get a handle on that, seeing a smattering of cases, and next week, the Kaiser Northern California addiction medicine doctors meet every 2 months to go over issues of importance, and that's going to be on the table as one of the most important issues we're tackling, to try to make sure that we're testing for it, and then it's being educated about for our patients, physicians, and it's a huge issue. And everything out there is fentanyl. So it was mentioned here. We've had patients come into the ICU with fentanyl overdoses who swear that the only thing they were using was marijuana. Okay, and their urine tests did not show THC, they just show fentanyl. So it's being put in everything, it's being put in everything. There's almost nothing else out there now. So again, I hate the disease of addiction, and I don't use the word hate lightly, ever. It's a devastating illness. It affects everyone. It acts like a shock wave. So, the person who's addicted is ground zero, and we affect everybody around us. It's devastating to families and communities, and I'm so grateful, that this panel was convened, and I hope to be able to see more of this in the future. So thanks.
Great. Thank you, Doctor. I appreciate it. Look, as we obviously wrap down, I think there are a number of issues that were put out there by our experts that are here, excluding me, at the front table. Obviously, you got funding for programs. You got legislation, federally, the whole Fentanyl Act, the Support Act, the Modernizing Opioid Treatment Act. You talk about social media, undersheriff. We talk about social stigma. We talked about telehealth. We talked about data sharing and the modernization of it, especially getting rid of, or at least adjusting 42 CFR Part 2. Narcan, test strips, vending machines for things like that, methadone, medically assisted treatment, and of course, care extenders. These are a number of solutions that obviously I think we are, basically charged with taking back and working on them together. Let me just kind of bring up something that I think obviously kind of sits with me and is kind of my prerogative being in this position. I was a former prosecutor for about 19 years, minus the year I was deployed. And I was on the drug team up in Alameda County as a prosecutor up there and then down in Monterey County. And one of the things that we had was this system called drug court. Okay, I think we all are familiar with drug court. And one of the benefits of it is that it was a carrot and stick approach, and that you saw it sort of work when it came down to it. It seems like the stick is no longer there. And so I was wondering, is that a way to look at this anymore? Is that a way to basically try to get these services that we talked about to the people that need it the most? Is law enforcement, are criminal courts, do they need to be a part of it anymore? Obviously, that's something we had back when I was a prosecutor in the 90s and early 2000s. Is that something that's working now? And under sheriff, I'll put it.
I'm so sorry to duck
No,
up.
not at all.
I will put my vote in, though, for a secure treatment facility as ideally an alternative to jail. But I think in some cases it may be necessary.
Thank you, Mayor, for
I'm
being
not
here.
the health expert here.
I appreciate it.
convening us,
Thanks,
and
Mayor.
apologies
I
for
appreciate it.
having
Not
to
at all.
duck
Not at all.
out.
Do your thing.
Thank
See you
you
later.
all.
Thank you, Mayor. Thank you.
Thank you, sir. Excellent question, and I really want to have a balanced answer because obviously law enforcement has a particular perspective. But what I will say is I feel like your analysis is correct, that the carrot's still there and not the stick. And what we've seen a lot in law enforcement is that the addiction is so strong that you can offer services over and over and over. And it's not until someone hits very rock bottom that they're willing to even consider an alternative to their drug of choice or their addiction. And even then, when they want to get help, it's hard to make different choices that the folks that are struggling with this type of addiction have been making, honestly, for years, many, many times. So we got to help them. We have to help them. And I can just tell you, I've been in law enforcement for 26 years. I was a detective for a lot of years. I've made a lot of arrests in many cases. And I've had people thank me for arresting them later on, after they've sobered up, got a clear mind, and realized that that was the step that they needed to help clear their mind and get some tools and resources to make different changes. So I think we can't overlook the combination of the carrot and the stick. Like you said, I love that analogy because you can't just have the carrot, but you can't just have the stick. You really need them both. And I feel like in the last several years, losing the stick, it's kind of been a perfect storm with the fentanyl opioid crisis and that climbing ladder on the graph that I talked about earlier. You're seeing those things happen. Doesn't mean causality. Could be correlation. It's a complex issue. There's a number of factors. But let's do what we can do on the things that we know are helpful. So I think we definitely need to have a balanced approach.
I guess I'd open that up to any of the doctors if they, would want to speak on that. Please, Dr. Hull.
Sure. Yeah, I think my perspective is that we need to offer more treatment options. I think that my experience with folks struggling with addictions, I have a really hard time getting everyone who wants treatment the treatment that they need and the level that they need it at. I think that, for a long time, not just locally, but in our country, we have not funded treatment well. And so especially when you think about the Medi-Cal population, we are not funding well, enough residential, intensive outpatient. And so for me, it's hard for me to even think about what mandated treatment looks like when I'm not even providing what I think is the top level of evidence-based treatment for those who want it. And so that's really my perspective.
If I may add, I think there's some of the ways in which the entire healthcare delivery system hasn't really taken all of the steps we need to support folks who are even connected with treatment. And so, for example, some of the way we penalize folks experiencing addiction, as Dr. Granovetter described, during their experience of a chronic disease is unlike the way we treat any other disease. So if I have diabetes and I have a piece of cake last night, nobody says, no insulin for you today. You failed your own behavioral component of this, so we will deny you the rest of your treatment. Whereas many of the ways we structure addiction treatment right now don't let people continue to have all of the levels of the support they've asked for unless they make every step of behavior change perfectly at the same time. And I think we're learning as a healthcare delivery system, as we understand how these drugs change your brain, that is not only sometimes impossible to ask of somebody deep in addiction, but going to do them harm, the people around them harm, the healthcare systems harm, and the types of harms we're seeing to the entire community. So I agree with Dr. Ho. I'd like to see us, as we consider any kind of mandated treatment, making sure that those supports really are there, that those flexibilities really are there to make sure both anything anyone asks for and anything we require of them really is feasible.
I guess, please.
Oh, I'm sorry. Yeah. No, I was going to say I agree with my colleagues. As far as the carrot and the stick model goes, I think there's good research that suggests that regardless how someone gets into treatment, if they stay in treatment, they can do well, even if they were coerced. And a good majority of folks that enter treatment, as Sheriff Binder mentioned,
of coerced.
Oh, well, carrot and stick with, jail versus treatment. Going to lose the spouse and the kids, if you don't go into treatment. You're going to lose your job if you don't do treatment. There are a variety of social, almost, survival, based pressures that come to bear on individuals with addiction to try to get folks into treatment. But you have to have the treatment there, as was mentioned. You have to have the services. And that would include individuals, say, that choose incarceration as opposed to treatment outside, to have services like in the criminal justice system, adequate services. And I know that's always been a huge issue in terms of resources needed. But, we've seen lots of folks who got sober for the first time, in prison and can stay that way. And that, also brings up the transitional issue about, how do you help folks after they've been released. So, there are so many different areas where the resources have to come to bear to allow people to get treatment over this whole lifetime of the illness, this chronic disease that we have.
Dr. Rudman, you said something that talked about the changing of the brain, and obviously that brings into the mental health part of this as well. And President Ellenberg, you've obviously been an expert and a leader when it comes to addressing mental health issues. How do you see that tying into this ever-pressing issues, considering that it's so connected?
I certainly agree with you. These issues are deeply connected. And I think part of what we've seen, not only as the drug supply evolves to a much more deadly supply, but the demand, I think, as Under Sheriff Binder referred to it, is growing too as folks cope with growing other mental health concerns without access to the treatment and supports and resiliency skills that they need to cope with those without seeking drugs. And so one of the things the public health department and the county as a whole has sought to do is, at the same time we respond to the opioid epidemic we're seeing, respond to the growing awareness of increasing mental health needs for both preventive services, community building, educational skills, and mental health treatment services that are desperately needed all over. And that may be one of the reasons folks are using drugs to help treat themselves.
Dr. Ellenberg, what have you? Yeah, obviously.
My father would have been so
sorry,
happy.
President Ellenberg. A lot of doctors up here.
I want to say something about the carrot stick piece. We had a giant stick until the 1970s, which were massive institutions for people with severe mental illness. That went away largely because they were proven to be, in so many cases, more traumatizing than curative. And to a large extent, they were really meant to camouflage as opposed to treat. The shift to community-based treatment was, I've come to believe and understand, the right way to go. The problem, which you've mentioned about capacity, is that when those services were transitioned from the state hospitals to counties, the funding didn't come with it. So I agree that until we have a fully built out system where people can get access to the treatment at the level that's appropriate at the moment that they need, we're really a step away from trying to talk about compelling treatment. And we do have some sticks. And what we're finding is that when we engage, and I'll give you the example of Care Court. Care Court didn't make any changes to conservatorship laws, but it works to create an additional court engagement, so that people who have been historically very resistant to services and have had multiple encounters with emergency personnel and with law enforcement to come to a court where they really are strongly encouraged, bordering on coerced, to go into treatment. And what we're finding is that when people get that kind of interaction, they do go into treatment. There have been very, very few examples where we've actually had to go to the compulsion. So really ramping up the field workers, the backpack medicine folks, the community engagement workers, I think can go so far in reducing the number of people who really are struggling without having to resort to a truly compulsory system. With SB 43, we're now having the opportunity to direct people into treatment for standalone substance use disorders, which is something entirely new. And it's something that we have to build out across the state. And it will be interesting to see, to get that data, to really understand how many people actually needed the compulsion, or if we did enough outreach, were we still able to get people voluntarily into treatment.
Now, obviously, you talked a lot about resources to do this,
Right.
which takes, I believe, a foundational solution, and that's funding, clearly. Where are you seeing this funding come from? And where can the federal government, obviously through SAMHSA, through the Support Act, where else can the federal government? Is it just, reauthorization of the Support Act? What other areas, what other levers can we pull at the federal level through the legislative process or the appropriations process?
And this is going to sound a little bit indirect, but hear me out. Currently, across our country, when people are incarcerated, they're held in custody even prior to disposition of their cases, Medi-Cal coverage is suspended, which means not that people don't get care, but the county general fund dollars have to pick that up. I think it's morally indefensible, frankly, to cut off people's health insurance because they are in jail. I don't know what message the federal government is giving by doing that. But that coverage alone, where we're spending hundreds of dollars a day per individual, would free up tens of millions of dollars in our county every year that we could use for preventative and upstream services. That would be, to me, the biggest piece of federal support. The second federal support is that there is a cap on building secure inpatient treatment facilities for serious mental illness at 16 beds. Particularly in this county, building for only 16 beds is economically impossible. So California has applied for a waiver. We have not gotten, the waiver hasn't been granted by HHS. If you help us,
HHS.
it is, but maybe you have some influence there.
Has the secretary, who is a Californian, has he mentioned anything? Have we heard from him on this?
I have not heard directly. I will be there next week
Got it.
as an officer for the California State Association of Counties to meet with several folks in HHS. So we will be talking about this quickly at the state level. If Prop 1 passes, it's going to do two sort of counterbalancing things. There's a $6.3 billion bond for infrastructure for mental health housing, some of it for locked facilities, the majority of it for unlocked. The counter to that, though, is that same proposition also has a reconfiguration of Mental Health Services Act funding, whereby the pot isn't growing, but we're going to have to shift funding that's currently permitted for prevention and early intervention more to the deep end services, which means for all of the things that the county experts are talking about doing is going to be that much more challenged. So federal support around prevention and early intervention would be significant.
Good. Well, I was 10 minutes late, and I think we've gone 10 minutes over, so I appreciate your indulgence in my tardiness to talk about these areas that I believe are very, very important. Obviously, there have been conversations about this. This has been a conversation about this important topic. There needs to be more conversations, but ultimately with the goal of reaching solutions, be it many of the things that we talked about. And I think obviously you've given me a couple of charges that I will look at from my federal perch in regards to Medi-Cal and the caps and other areas, and obviously making sure the Senate does its job on passing basic legislation, which sometimes they can have a hard time doing. But that being said, it doesn't mean that we just give up. It means, to me, it motivates us to continue to go forward. So I obviously want to express my appreciation for all of you for being at this table, for being willing to talk about this, but more importantly, being willing to reach a solution. And then thank you to the members of the press that were here and the members of the audience who are willing to come out and listen and hopefully learn something as I did. But obviously with the sort of edict that we can't stop here. We can't stop here. We have to continue to have these conversations, which I look forward to doing, so that we can come up with solutions to this ever-pressing problem in our community and ultimately across the country. So look forward to continuing to work with you. And again, thank you very much.
Thanks so much.
Thank you.